So we are going to talk about abdominal wall, hernia, and the umbilicus. So abdominal wall is covered by superiorly there is a covering that is called as a diaphragm, and inferiorly there is a pelvis, that is bony part. But there is also you can say this part is the central muscular portion, which is called as perineum, and there are certain areas from where any viscous or in a part of the viscous can protrude and can be a part of hernia. One can say the definition is like any abnormal protrusion of an organ tissue through an opening in the layer that normally confines it. So for example, in the midline, when there is like two component like rectus abdominis is separating from the middle, then it is called as divarication. So divarication is not an hernia, it's just the defect which do not require any surgery, and if it is done, it is mainly for the cosmetic reasons. So perineum, this central muscular portion can have certain like defect in the form of prolapse. It can be rectal prolapse, it can be uterine prolapse, it can be cystocele. And then in anterior abdominal wall, we see there are various sites from these organ or any viscous can protrude. Mainly we see the inguinal region. And then posteriorly we have something called as lumbar triangles, which are like superior lumbar triangle, this, and we have inferior lumbar triangle. So these are the areas from where any viscous can protrude and can cause superior lumbar hernia and also the inferior lumbar hernia. So in the central portion is formed by the umbilicus, is composed of 4 distinct anatomic structures. So these are the mainly the structures: the cicatrix, the mamelon, the furrow, and the cushion. So cicatrix is the central portion, that is the dense scar actually, and it is fusion of the several peritoneal and the fibrous structures. It includes round ligament of liver, and it includes median umbilical ligament in the center, and laterally 2 medial umbilical ligaments, and also the transversalis fascia is the part of it. Umbilical fascia and parietal peritoneum forms a dense scar which forms the cicatrix, and it is the central portion. So we have already read about what are the various positions from where any organ or any viscous can protrude. It can protrude from the diaphragm, it can protrude from the perineum, it can protrude from the inguinal region, it can protrude from the lumbar triangles, which are in the form of superior lumbar triangle and the inferior lumbar triangle. Then there are various causes for hernia, mainly the ventral wall hernia. So what are those causes, which are further divided into one can say the anatomical weakness, then the developmental failures, then the genetic weakness of the collagen, then sharp and blunt trauma, or it can be because of weakness due to aging or pregnancy, or because of certain neurological and muscle disease. So anatomical weakness is which is mainly described in literature is the processus vaginalis, which is responsible for indirect inguinal hernia. Then developmental failures, which can be in the form of collagen disease, which we have already discussed here. So it is a inherited imbalance in the types of collagen. Then it can be because of genetic weakness of collagen, which is the part of it. Then can be in the form of sharp and blunt trauma. And these hernia are usually common in the smokers, and in case of extreme collagen disorders like Ehlers-Danlos syndrome, and also common in elderly people. So one can say these are also kind of people where these things are common. Then incisional hernia, which are commonly seen after the wound complications and usually associated with high BMI people. And the major risk factor which is described is, usually we should not say, but the surgeon is the factor. And then the way which abdominal wall is closed, this is also a important factor which need to be kept in mind. Then then when we talk about hernia, so there is usually sometimes the content can be extraperitoneal thing, or it can be intraperitoneal thing. So extraperitoneal, it usually it can be in the form of fat, or it can be in the form of urinary bladder, where in the direct inguinal hernia. And then in intraperitoneal, the structures are usually, it can be either reducible or irreducible. So the content can be either it can be intraperitoneal or it can be extraperitoneal. Then if we talk about types of hernia by complexity, so it can be a occult hernia which is not detectable clinically. Then a reducible hernia, a swelling that appears and disappears. Then irreducible hernia, a swelling that cannot be replaced in the abdomen at the risk of complication. Then incarcerated, incarcerated literally means something that is in prison, means it is a irreducible hernia and it is trapped and there is a risk of strangulation. And a strangulated hernia is a acutely painful swelling with tissue ischemia and it requires emergency surgery. And a infarcted hernia is when there is the content of hernia have become gangrenous and it is associated with sepsis and high mortality. Sometimes what happens, usually a part of any viscous, like for example there a part of bowel only, like a wall of the bowel can be a content of hernia, then this is called as Richter's hernia. And then it is called Richter's hernia. So or it can be in the form of interstitial hernia, that is from between the layers of musculofasciocutaneous layers. So usually these hernias, the one of the common hernia that is known is esophageal hernia. Then internal hernias, which is a different topic, we will talk about it. Then if we talk about inguinal hernias, then we have mainly direct and indirect hernia, which is classified on the basis of, there is something called as Hasselbalch triangle. So Hasselbalch triangle is formed by the medial part is formed by the lateral wall, the lateral part of the rectus abdominis, and the lateral wall is formed by the inferior epigastric artery, which is branch of external iliac vessels. So indirect inguinal hernia, it passes through the inguinal canal, and the direct inguinal hernia, it bulges from the posterior wall of the inguinal canal. So indirect hernia can descend into the scrotum, but the direct inguinal hernia usually do not descend into the scrotum. Then we have already discussed that it is lateral to the epigastric vessel and it is medial to the inferior epigastric vessel. Then if we reduce, it goes upward, then laterally, and then backward. But direct inguinal hernia, on reducing, it goes upwards, then straight backwards. So controlled after reduction by pressure over the deep inguinal ring, we can control it. But the direct inguinal hernia is if we put our finger over the deep inguinal ring or the internal inguinal ring, we cannot reduce it because it is the direct protrusion from the posterior abdominal wall. And in case of indirect inguinal hernia, the defect is not palpable because it is like a natural opening from where the hernia is coming. And in case of direct inguinal hernia, one can feel the defect because it is basically the weakness in the posterior abdominal wall that is above the pubic tubercle. And in case if we reduce it, the indirect inguinal hernia, and when the bulge appears in the middle of the inguinal region, then it flows medially before turning down to the scrotum. And contrary to it, indirect inguinal hernia, after reduction, the bulge reappears exactly where it was before. And if we talk about the age group, so the indirect inguinal hernia are common in children and young adults, and the direct inguinal hernia is common in old age because of the weakness of the posterior abdominal wall. So that's all for today. We are going to discuss. We'll talk about how to repair these hernias, the laparoscopic ways, the open repair of the inguinal hernias in the next topic or the next class. Thank you.